talking about what it's like to be in a hospital during a pandemic. We have with us today Dr. Tracy Stiller. She is board certified in internal medicine and is a hospitalist at St. Anthony's right down the hill. She also happens to be the medical director at Mount Evans Hospice right here in Evergreen. She went to Columbia University, Miami Medical School. There, she specializes in end-of-life medicine, orthopedic perioperative medicine, say that 3 times very fast, as well as global medicine, where she did recently went over to Chiang Mai, Thailand there. And most importantly, she happened to do residency just a few years ago at St. Joe Hospital in Denver, where she trained with side by side with Dr. Marcia Manning. Imagine that, who's right over here. And then we have Dr. Greg Stiller. He's board certified in emergency medicine, and he's got fellowships in emergency medical services and wilderness medicine there. He's currently working at Evans Army Hospital, and he's a physician in the United States Air Force National Guard. He went to Brown University, then went on to the University of Buffalo School of Medicine. He practices austere and tactical medicine. I'm not sure what that is. And then he's trained as a United States Air Force flight surgeon, ground surgical team physician, and he volunteers here in Evergreen with the Alpine Rescue Team, where he saves more lives there. And he's deployed all over the world. Matter of fact, he's going to be deployed here in July again to whereabouts that is classified. And as you might know, they both have were there for Ground Zero on 9/11, Hurricanes Andrew and Harvey, the Cuban and Haitian refugee crisis, HIV epidemic, and wartime medicine. And somehow they managed to catch each other long enough to have 4 children. So with that, Doctors Stiller, take it away.
All right, thank you, Bill. Can you all hear us?
Yes.
All right, and we're going to try to figure out how to do a share screen here with hopefully the help of my 4 teenagers. Is that up and going for everybody? Everybody sees that all right?
Yes.
Yeah.
All right.
Looks good.
So as Bill was saying, I'm an emergency medicine doc, and Tracy's a hospitalist, which is basically the internal medicine doctor that covers in a hospital. So her job is to take care of all the inpatients as well as if anything goes wrong in the hospital. And we're going to just briefly talk to you guys about the challenges of working in a pandemic. We're going to kind of avoid a lot of the technical numbers and statistics and stuff. We hear all of that on the news continually. So we figured we would go into more of a personal tilt on what we're experiencing and what's actually going on at the ground level.
So how did COVID become a pandemic? First to point out is the World Health Organizations and the epidemiologists have predicted and planned for this for decades. So first I would leave the surprise behind that we're here and dealing with this. What makes it a pandemic? Why is COVID such a good virus? First off, asymptomatic transmitters. People are well, they're out of the community, they're traveling globally while transmitting this virus. There's a high rate of transmission during this period, person to person. The transmission initially is still getting sorted out, but appears to be multi-route. And there's a long delay before the infected person might get sick enough to not travel, be home, and present to a hospital or a care situation. Many days from exposure to death leads to a long transmission period. Compare this to Ebola, which we've talked about for a long time. Ebola is a less transmission period. It's a very short latency to the period where people are ill and then die. There's no time to travel. There's no time to infect other people. The ease of global travel has really made this an issue. As Carol mentioned, in Africa, it's in Africa because of airplanes. That's how this has been allowed to travel so easily. Right now, there's a lot of discussion about delay in reactions by the World Health Organization, government reactions. that have contributed to the severity of this global epidemic. The economic versus the social impacts of what's going on has brought this to everyone's attention. In this case, that people have not been as affected when H1N1 came through, when the swine flu and other issues have come through. It's a new virus. We're used to the flu. We're not used to COVID being so impactful to our personal lives. So there's also been the concern about a delay in global information sharing and what to do, and delay in preparedness from an individual government. But leaving that behind, I would ask to leave the surprise behind that we're here. I would ask to engage in the resiliency and responsibility individually of being in this situation and step forward in dealing with this pandemic.
All right, so talking about it from the emergency department, I kind of divided it into several different categories. And I would say the early stages, where we didn't know what was actually happening. We were grossly unprepared. We had a lack of information, and we also didn't have the equipment or the facilities. So when I was first working in the ER, hearing about what was happening in Wuhan, we were already having patients that were COVID positive and didn't even realize they were in the United States yet. Where I work currently, we have a lot of deployed soldiers that come back from all over the world. So we started seeing it quite a bit earlier without even knowing it. The other issue is distinguishing COVID from the background caseload. We're in the middle of flu. So we were seeing tons of influenza A and B, and then we started seeing more coughs and congestion. How do you make the transition over to even realize that we've become affected? And that goes into pulling the trigger. When we pull the trigger about seeing a patient and addressing them as COVID, we talk about full PPE. And every time we do that, we're using that supplies. So how do we judge an asymptomatic versus a minimally sick versus somebody who is grossly COVID positive in terms of putting on all of our gear? The second part of that was the ramp up. Now we know that we have COVID in our community, and we're working on getting more and more PPE. We're changing over our facilities. We're dealing with all these different patients at this time, and we're trying to deal with these loads. So we have a high suspicion for COVID, which often misses other diagnoses. Now when someone comes in with a cough and a fever, first thought is COVID. We don't think about straight up influenza, which there's a lot of co-infection, which we've learned subsequently that you can have both. As you can see, equipment's changed. At the top left, you see a picture of the original equipment we were using, and it's a yellow procedure gown, not approved for airborne. There's nothing about this gown that makes it safe for taking care of COVID patients, except for it's better than nothing. And so we've adapted. As you can see in the lower picture, you have a woman wearing a face shield and a mask. The mask is not an N95. It's not approved for aerosol. This is our niece, actually, who works as a nurse. Once again, doing the best we can. So after this point, we move into what we're doing now. So we're getting into full PPE, and as you can see, there's Tyvek suits and there's PAPRs. PAPR is a powered air purifying respirator. So what it does is it puts a shield over your face and basically blows air into there, pushing everything else out. So you don't bring in outside air particles, you're pushing them outward. It's got a couple of limitations, as you can probably tell by looking at it. It's pretty cumbersome. It's got a battery pack. It's difficult to clean. You got to use them over and over and over because we just don't have that many of them. In our ER, we have one suit per COVID room, meaning that all the staff use the same suit because we don't have enough to use them one at a time. We also don't have specialized rooms. We don't have antechambers where we can change in and out of protective gear. We don't have a negative airflow room, which sucks the air out and blows it away from people. We don't have a separate ingress and egress. So if you walk into an ER, there's a chance you're sitting next to somebody and getting co-infected when you're there for a sprained ankle. And we also didn't have a waiting room originally. So what did we do? We had our patients waiting in their cars to prevent spread. So now we have a full screening center where people are met at the door. They're screened with temperature check-in questions and sent over to a whole separate facility if we feel they're COVID positive, so that we can continue taking care of emergency patients. And that's been kind of the hardest problem. And our current challenge is high-risk procedures. So we've learned that intubating patients is incredibly high risk for the providers to pick up the disease and spread it. And the other thing that we're starting to debate is whether viral load has an influence. We've noticed that a lot of healthcare providers are getting sicker even if they're in the younger age groups. And part of the question is this because of how much we're exposed to at a time? Then we went into what I call right now is our cruising and bracing. We're cruising along. We have some plans in place. We have a standard level of PPE that we're using regularly. We have some good evidence coming out now. It's evidence-based as opposed to before it was based on people's individual experience. So we're starting to develop formal protocols. And moving forward, we have a good separation of our primary COVID versus our non-COVID or potentially asymptomatic patients. We're dealing with PPE as we saw, and we're definitely up to full equipment, but now we're getting into shortages and we're doing recycle programs. As you can see the picture on the left, those are our N95 masks that we use for our non-COVID, since we're using PAPRs now. You can see after a shift, you are supposed to wash it down, throw it in a paper bag, and leave it till you come back for your next shift. We use one mask for every 3 days to try to keep our supplies up. Mine's the one in the middle. The one on the right is one of my colleagues who is now at home because he's positive COVID. So it's a little lean still, and providers are still under a little bit of stress regarding this. We have developed a COVID ward at this time. My hospital, my ER split in half physically. And we have one side that is known COVID and the other side is for people that are, quote, you would call clean, but things like injuries and trauma and heart attacks, we're trying to keep them all separate so that we can take care of them appropriately. And then the last phase, which we have been lucky so far in Colorado to have not hit fully, is becoming overwhelmed, where we have a depletion of PPE, we get into conflicting information, we deplete our ventilators, and we wind up having to start to choose who we're going to have to treat. And we have not hit that yet. And we have a little advantage in Colorado because we did not have certificate of need, which means in a lot of states you have to have a need demonstrated before you can build hospitals. And Colorado is very heavy on hospitals, in Denver specifically. So far we've been able to spread this out and tolerate the load.
So let's move deeper into the hospital setting. And I want to take the picture of the mask to kind of explain what the limitations and the issues are regarding these. If you look at the picture of the mask, the top two masks, the yellow mask, the blue, and the mask on the yellow mask and the other mask below it, the blue mask with the single strap, they're very basic hospital masks. They actually do not provide significant protection from any airborne illness. What they do is they decrease the amount of droplets, large droplets that you may breathe in. They're not fitted masks, and they're not appropriate to use to prevent the transmission in a closed environment with a known positive patient. The two masks on the left are these N95 masks. What they do is they're fitted, and they don't necessarily work unless a provider knows how to put them on and fit them for an air seal. The community out wearing them generally have not have been trained in how to fit them or how to use them properly. They have a filtration fiber that goes to a micron that actually would catch this virus. We have no testing and we have no information on the reuse of them, which is currently what so many providers and so many hospital settings are needed. But it's the lack of these N95s that are putting the most stress on providers walking into high-risk situations. So let's talk about what we're doing at the hospital for protecting providers. Shifting from the ED to an ICU setting. So standard, what most hospitals are doing is coming up with what we call a COVID ward. And what would that look like is a known positive where then both the providers and the patients are isolated, dealing with high-level preventative equipment, the PAPRs, the full gear to prevent the transmission. We then will have a COVID pending ward where certainly our concern is high, our tests are pending. If a pending becomes positive, they get moved to the full COVID ward. Once you're on the COVID ward, assuming that everyone and all the patients there have it, certainly the triage and how it's treated becomes slightly different. The patients are our vectors. We want to prevent that from getting transmitted to our providers. Versus a COVID pending ward where the delay in tests has certainly impacted how we're dealing. But again, do we know that our patients are positive? We don't. Do we suspect? Yes. but we still treat our patients as the possible vector. We want to protect our providers delivering the care. We want to provide them with an appropriate N95. How else have we adjusted at the hospital? We've canceled procedures very quickly. 2 and 3 weeks ago now, all elective surgery procedures were canceled throughout the Denver area. What this does is it frees up beds, it frees up providers, it frees up nursing staff to be able to rotate through as we were dealing with more COVID cases coming in. We shut down our hospitals. The visitor policy in the first week was only 1 visitor allowed. We don't have the gear to protect the visitors coming in. The visitors present a possible new vector for our hospital system, and now the visitor policy is 0, leading to the very unfortunate and sad situation where anyone ending up in the hospital is by themselves. We're retraining the physicians and the nurses to new tasks and new employment. We're introducing people on how to protect themselves and deliver care in environments they've never been in before. What do we do with staffing in this situation? Because not only are we talking about the possible vectors with the patients coming in with this, but we're talking about the vectors of each other now. Right now, and this has been evolving over the past 3 weeks. Initially, an exposure would be put the provider in quarantine. That's no longer applicable. We wouldn't have any providers. Everyone is exposed. If you do not have any symptoms, you continue working. If you develop symptoms, you are out of the field until you've been tested positive or negative. What we've done to change our care interventions, as we've developed more information, we know that anything that aerosolizes respiratory secretions become a high-risk intervention. Greg talked about the intubations. We really feel the viral load transmitted during an intubation of a COVID patient is a high-risk situation. We know that using nebulizers, which are aerosol inhalers, increases the possible risk of transmission of this virus. We avoid doing this. What we also know as we move to CPAP and other respiratory interventions, that right now the recommendations is do not use CPAP unless you're in self-isolation. A CPAP is a personalized device to deliver pressure oxygen at home, specifically used in the case of lung disease and sleep apnea. Let's look at the long-term facilities, especially the ones here in Evergreen. The first thing the long-term facilities did correctly and well is they initiated a no visitor policy. Why? Because we're going to assume right now our facilities are clear of the virus. The risk to our populations, high-risk populations in our long-term facilities are people bringing it in, is the visitors, is the families. So they became on lockdown very quickly. Again, we have to worry about our providers and staff and their ability to prevent transmission coming into the long-term facilities. Availability of the personal protective gear has been limited. Again, we're reusing personal protective gear with unknown efficacy. What the lockdowns have done in terms of providing care for these patients, we want to do only critical visits, decrease frequency of services. Any outside services have been stopped. Social interactions with family, with all the community situations that are involved in bringing stimulation into these, they've all been stopped. But the potential for outbreak in a long-term facility, a lot of these people are roomed in a 2-to-1 situation. There's no place to move them. We can't do social isolation when you have 2-to-1. We can't handle an outbreak in quarantine in a long-term facility. So the picture on the upper left is the creativity of the facilities and trying to remain engaged. This is called hall bingo. And so maintaining 6 feet apart, trying to keep the residents engaged. The residents are being kept in their rooms. They're not going for social meals anymore. Meals are getting delivered. Do each of these interactions represent a possible transmission of the virus? Yes, they do. We do expect the social withdrawal, depression, and an associated death rate related to this to occur in the long-term facilities. Yes. Are we trying to save lives in a at-risk population? Yes. Let's go to in-home care. Again, when we look at who's at risk and who's at risk of transmitting, the people in our home environment in hospice, that's considered to be a clean environment. It's the providers are the primary risk and primary vector of bringing this COVID into their environment. Again, what have we done at Mount Evans? We've come down to critical visits only. We've changed to phone visits. When we have families that are able, yes, we've gone to online televisits. We've tried the quarantine and isolation, which we put in place for our staff, are much more strict than what we're doing at the hospital. Any signs of illness, any known exposures, we're pulling them out of the field for our patients, and making sure that we have a negative test and following the criteria that you're asymptomatic for 7 days before returning to the field. On the home visit on the upper left, walking into this patient's home, there's a food box sitting on the doorway. The patient wasn't aware. The patient has no capabilities of going out and getting that. What if there wasn't a critical visit going on that day and hadn't walked up, picked up that food box and brought it in? Some of these logistics we're working with. The delivery of medications to our home visits. How our providers, we're asking them not to do any personal stop-bys to grocery stores, to go into these visits clean and save any additional exposures to the end of the day to hopefully not bring it in. At Mount Evans, we have been able to procure 95s and a gown to be able to make these home visits as safe as possible for our at-risk populations.
So let's talk a little bit more about our personal experiences. As you can kind of tell from what Tracy's saying, it becomes a little dance with who's the vector. You know, originally it's patients coming into the hospitals that are predisposing the providers. Now the providers are considered the high risk. So we have to kind of modify our behavior going back and forth. And in a disease where 80% is going to be asymptomatic or minimally sick, which as we heard earlier is not really minimal, it's still pretty brutal. But we're dealing with the ones that we're most concerned with, those that are going in to be severe in the ICU and are going to need ventilators. So here's an example of my day. I arrive at my hospital. I wear a pair of scrubs from my home. Once I get to the hospital, I grab a pair of hospital scrubs and change into them. I put a mask on in the locker room. I put my cell phone in a plastic bag so it doesn't become a vector. And then I head out and I work on the floors. Some of the days I'm wearing an N95, seeing patients that are low risk or quote non-COVID, taking care of the routine things, broken bones, heart attacks, strokes, colds, coughs, congestion that are not related. At the end of the day, I walk back to that same locker room. I pull off everything I'm wearing. I jump in a shower in our locker room, clean myself up. I put myself into another set of scrubs for my drive home. Once I get home, I take off those scrubs and throw them in the garage in a bin. And then I jump in the shower again. And then I get to start individual isolation, which Tracy and I have discussed how we manage this. I have friends who are living separate from their families. I have friends who live with their families and don't isolate. The vast majority are doing individual isolation in their home. So I sleep in a separate room. I have a separate bathroom that I use. I stay 6 feet away from my spouse and my children. I eat at a separate table. I don't hug my kids. I don't even pet the dogs. I wash my hands quite a bit. And that's the nature of our life right now. How long do I do that for? How many days do we do that? 7 as a normal isolation? The problem is every time I go to a new shift, there's a reset and they start all over again. And without knowing the end of this and the predicted end, there's no way to modify it. A couple days ago, I get called up and told that my staff members were COVID positive and that I have to go for a mandatory COVID test. So I start calling around and we hear a lot about people, you know, first responders and ER docs are able to get tested. Nobody in the city will test me because I'm not part of their system and they're low. So I drove an hour and a half and got my test done, which was supposed to be 24 hours, which took 3 days, of which I'm fully isolated and not able to work. And then finally got my result back, which this time is negative, which is why I'm sitting next to my wife currently instead of isolated. Decreased and increased employment. So physicians are getting hit on both ends. Some of us are being overtasked and asked to work continually, and some of us are not able to work at all. So a lot of the elective procedures Tracy was talking about, those doctors are being retasked. And while all doctors are trained and they're all qualified, they all have different specialties. So when you start asking primary care physicians to be up on a floor intubating, you're putting people out of their well house and you're making it quite a bit more stressful. But what's the alternative? Discussions of what if. Tracy and I have had a lot of talks in the past 4 weeks about our will, about the exposure of our family and how much we isolate, about supporting local versus volunteering around the country. I've been called 3 to 5 times a day to go to California, to go to New York City. The downside of going to New York City is it's 6 weeks gone. Colorado hasn't hit its peak yet. What happens to my local community if I'm gone and I can't help? What happens if 100 of us go and we're not here to help? It's that debate where you feel you can do the most good. Other conflicts, I want to do more. I want to go to New York City. I am set to deploy, as Bill mentioned. I'm on a military hold and I'm not allowed to leave the state. So I don't have a choice about going to New York City at this point. Adjusting perspective. After working in the hospital all day and every single thing you touch is a vector and you're dealing with critically ill people, everything else is a little skewed when you come out. So you go to the supermarket or the gas station or Home Depot, and my view of those is it's a relatively safe environment compared to the stress of people who are staying home and are going in there. So modifying our perspective when we come out of the hospital has been an interesting phenomenon. Keeping in touch with people. It's really easy for us to get inundated by the COVID news and sit there watching news all day and forget to reach out and talk to other people. For us, the biggest issue is it's hard to deal with just the routine daily things that people talk about after you come home after a day that's been miserable. Keeping our elderly parents away. We both have parents well into their 80s. I have mine sequestered in their home. They're not out of the house at all. They've been there for a month straight with people coming by to drop off things to them. My mom keeps asking when she's going to see me, and I know that I am probably the highest risk that she has. And then deployment. I'm going to be leaving in between a month and 3 months without knowing. And I may not actually get a chance to see my kids or my wife up close after my next shift tonight before I deploy for another 5 months. So it's been a very interesting personal experience. And I think the amazing part of any crisis like this is how people rise up to help. We see the worst and the best in mankind when we're under stress.
So this was a picture drawn and put up at St. Anthony's Hospital. And this is my new life goal is to be a pirate doctor. And I think the cruise ships need pirate doctors now. Long-term concerns that the situation is still clarifying for us is what about the survivors? And here in our mountain community, one of the things I'm worried about is there going to be a subset of people who are going to be on pulmonary disability after having had this virus and the cytokine and the pulmonary damage. We live at altitude. A pulmonary issue long-term in our community is going to be very impactful. Any questions?
I'm having a hard time getting that video up.
Yeah, I have a question. Great presentation. That was absolutely fantastic, and really appreciate the timeliness of this. I'm in the middle of filming the Denver Convention Center, Colorado Convention Center, and the build out of the 2,000 plus beds or approximate 2,000 beds. What's the thoughts on that? Are we really going to need those or not?
So Denver's a unique situation. Understand, we have 11 hospitals within Denver. We right now have dispersed our COVID situation very well. And I would compare this to going north and south along the I-25 corridor. South of us in Colorado Springs and going to Pueblo and going up north to the Fort Collins area, they're down to 1 to 2 hospitals. They're under a lot more stress. The problem with building it in Denver is this where the need is going to be? And the second problem is dispersing our positive COVID. We don't at this point have the right protective equipment to protect the people transporting these patients. So having a central area may be used, but Denver has a lot of capacity still. Most hospitals are running around 50, 60% beds right now, mostly, and with 1 COVID floor with the potential to go to 2 COVID floors. What we don't have is our ability to transport and offload our hospitals north and south of Denver because we don't have the ability to protect the transporters right now?
I think the best answer is there's no way to say. That largely depends on whether we continue to grow or if we've actually hit our top and we're leveling out. And there's no way to predict it. I think the best thing is to say we're better safe than sorry. I think over preparing is the better part of valor when it comes to dealing with human lives.
This is Larry Fitzsimons. I have a question. After this is over and the stress that you are and all your colleagues are under, do you think there's going to be a large fallout of people leaving your profession?
That's a good question.
It's a good question. I think one of the reasons I love being in medicine is the commitment and focus and intelligence of the people that I work with. I hope that people will draw on their intelligence, their resiliency to see their way through to the goals that we all have as providers. So I hope not. I think there will be some people who will have some form of PTSD of having to deal with this. The stress really lies in us wanting to do our jobs well, but also protect ourselves and our families from us doing these jobs well.
And I think your question's it's a double-barreled shotgun because you have to address each specific area. You know, an emergency physician versus an orthopedic surgeon versus a nurse versus a respiratory therapist. You know, their exposure and their dealing with this is going to be quite a bit more extreme, and you're going to have to address each specific area in terms of who's going to be able to keep it up. But medical professionals, this is what we're trained to do, and it's what we do. It's the hardest thing to explain to people is why we do this, why go into a war zone to take care of a guy who's wounded at personal risk. That's just not the way we think, and maybe we're a little clueless and don't think enough about our personal safety.
Greg, I have two questions. One, going off of what Fitzy has to ask, how are you helping yourself mentally to it sounds like you're in a very stressful place, not only in your workplace, but your upcoming deployment. That's question number one. And question number two, how are you dealing with, or have you had plans with these outbreaks, say like in the Weld County Jail with these inmates, and how are they, do you know how they are planning to deal with people who are incarcerated?
So in terms of the incarceration, it's that I'm not able to answer. So the weird thing about this whole thing is that each system is developing their own plans. So I can comment on how Colorado State Patrol is planning on dealing with this, but in terms of prisons, I'm not in the system and I really can't answer much in terms of it. In terms of personal dealing with it, my number one saving is I have Tracy. But secondary, working out every single day, go for a walk. I go walking with my kids because it's one of the few things I can do. They're all teenagers and they're all 6 feet ahead of me no matter what. So I can walk with them and talk and catch up with them. And I feel that's kind of the value that all the physicians really and the providers need, is to keep a balance at home, keep a limit on how many shifts. I've started stacking all my shifts into groupings. So I'm working 5 in a row coming up, and then I'll have 5 days off. Time to decompress and time to kind of keep perspective. I think the other thing in terms of dealing with stress in terms of the healthcare providers is the level of experience. Medicine is an indoctrination into bad things. So, med students, they get their dosing of seeing bad things happen, and then you become an attending. And then when the bad thing happens, it's your responsibility. And as we get more and more years under our belt, we generally can tolerate a little more at a time.
I would add to that is the same resiliency that each of us individually, as our lives have changed, we draw on that. And here's what I would normally do, but I can't do that. So I need to come up with a new plan and a new pathway to help me go forward. And we coach each other in it. We coach our children in it. We coach our colleagues in it. And each of us individually are coaching ourselves in it. And I think part of a Zoom meeting and getting together is to be able to share experiences. Some of it is for us, it's a professional stress as well as a personal stress. For each person, there's going to be individual personal stress, economic stress, and you support each other through it. And you pull on those supports. I think the meeting and everyone getting together in the chat beforehand is part of this group's resiliency.
Hi, this is Brenda Jansen Belrose, and I actually have 2 questions. First, thank you for your personal sacrifice in doing this because it's huge. My questions are, how do you view this from the local level, respond to everybody who wants a test can get one? What are you seeing in that vein? And the second is the statement that, gee, just as many people died from H1N1, what makes this different?
Do you want that or you want me?
Well, to address it a little bit backwards, what makes H1N1 different than COVID? First off, we know the flu. So even though that was a quote, a more virulent strain of the flu, we knew what to do. We knew seasonally it would go down very quickly because we already know how to make a flu vaccine, and we already have Tamiflu, some antiretrovirals with some efficacy. We had a treatment. So people sat back and said, oh, we've done this before. And as a health community, even though it stressed the system at that time, and we were pushing how many ventilators we had, we were pulling out the same protocols they're talking now. How do we ethically decide from a hospital committee who gets the ventilator if we have more patients than ventilators? We were there at that time too. It didn't hit the community. But we actually, again, we had a treatment. We knew the flu. We had a vaccine. We had something we could do. We don't have that with COVID. COVID is a new virus in this community with no immunity related to the proteins that this virus brings in. So that makes COVID very different. We have no treatment, we have no vaccine, and we have no prediction of whether there'll be a seasonal variation. This is a good virus.
So in your second question in terms of everybody testing, so there's 2 sides to everybody testing. With 80% of people minimally symptomatic, testing would allow us to actually understand what our numbers are. You know, we all are following how many new cases are happening in Colorado, but it's not really relevant if we don't understand how many are actually being tested. If we test our entire population, then we know whether we're actually going up or whether we're just detecting more. I think the hardest part of it is when the tests are short, we need to use them appropriately. So somebody who's admitted in severe respiratory distress who gets put on a ventilator, knowing whether they have COVID or not is a markedly different thing than a standard pneumonia or a COPD exacerbation or just asthma. So to be able to tell that difference is pivotal, and that's where a lot of the tests are going. Same thing as we talked about earlier, is we don't want providers walking around to sick people and giving them COVID. So I think at one point, I think the testing around the clock is great. I think for epidemiology and understanding these numbers, it'll be fabulous. I think maybe more important will be antibody testing to know who's been exposed in the future, because in addressing to what Tracy said earlier, once our population gets up to a certain level of exposure, it's no longer a novel virus. And we begin to develop herd immunity, which is one of the reasons why H1N1 is not as severe as this, because we do not have a herd immunity yet. And that's usually between 60 and 80% of the population having had an exposure, and then suddenly the rates start dropping precipitously because of that herd immunity.
So I just noticed in the chat room the question about respiratory therapy and what this looks like for getting the severe respiratory complications. So to understand viruses, the respiratory complications don't come directly from the virus. It comes from the inflammatory response that our bodies produce to try to fight this virus, this cytokine storm that you start reading about. When this happens, it's acute, severe, and quick. So what we're seeing in the hospital is within 24 hours, we'll have someone needing 3-4 liters of oxygen suddenly going into an intubation cycle. Now, again, that intubation cycle becomes a, quote, high-risk procedure in our hospital setting. And who does that? Who's on that team? Make sure they have the proper protective gear going into an intubation cycle. The other thing that's become interesting is we found that we're having people with significant hypoxemia that don't need to get intubated. And part of the problem with the intubation cycle is two-form in the hospital. Number one, once someone is on an intubator, we're having to need high levels of pressure, which is damaging to the pulmonary tissue. And that pressure in that high pressure situation, people are intubated for 2, even 3 weeks. The death rate on the ventilator is high, becoming somewhat country dependent. Right now in the US, the initial numbers are running about 50%. So if you end up on a ventilator, we're predicting a 50% mortality. The lung damage from the high pressures, again, where is that, even if people do get off the ventilators, where is that going to put them in 5 months? Are we going to have pulmonary disability related to this? What we are finding is that some people tend to tolerate the hypoxia pretty well. And my system has come up with the idea of happy hypoxia. We used to say once you're up to 6 liters of oxygen, we're predicting an intubation cycle for that patient. Now we're saying 6 liters, but otherwise looks well, clinically well. Let's follow these people.
Trace, there's a question about CPAP if you want to expand.
Yeah, there's several questions in the chat, and I know we're going over, and there's only a few minutes left, so if I can just like focus on the questions that are lingering in the chat, and we'll answer as many of those and not introduce any new ones. And thank you so much. Yes, CPAP was from Bob Rose.
Okay, CPAP, continuous positive pressure. Those are home machines, again, usually used for sleep apnea or pulmonary diseases, and people have them in their homes. We're providing pressure in that situation into the lung system to correct the underlying problem. That pressure also then comes out with increased respiratory particles. That is where that risk lies, and what we're finding out that CPAP with COVID is an increased transmission cycle. So if you're using a CPAP, you should be in isolation. We don't let people use it in the hospital right now, okay? So it's one of the respiratory tools that have generally been in our repertoire to use with respiratory illnesses, people needing extra respiratory support. We provide a non-invasive positive pressure situation. What we're finding is that non-invasive positive pressure situation increases particularly.
Over to Bill Manning had a question as well. Bill and Marcia.
Dr. Marcia has a question.
Dr. Marcia.
Hi. Good to see you both. I do have a question going forward. As I speak to our patients and other people now, I tell them that this is an issue that will be around for the next 12 to 18 months until we have an effective and safe vaccine. People are only looking to the current social restrictions, and really it's a whole new world out there as to what we do going forward. We're coming up with protocols as far as what we do in our office. We know we will still see asymptomatic patients who spread. We know we will still see patients who are pre-symptomatic who spread. We know, we hope we'll have better testing. We know we'll have antibody testing. Of course, it's dependent upon how good that antibody test is that these people have, but we're still going to be at risk. Again, I'm trying to bring that to everyone's attention. We're coming up with protocols. What do you both see in the hospital coming up as far as how you will handle this?
So I think this is a good point of discussion. Our hospital systems are business. And right now that business is shut down dealing with this crisis. Where are we going to cross those economic lines where we're going to need to open up our business for others again, for those elective surgeries? How do we keep those elective patients? Are we going to have two different systems going forward? Are we going to take a hospital and say, this is where we're going to make money and this is where we're going to take care of COVID patients? Again, 12-month cycle, 18-month cycle, when are we going to get a vaccine? When are we going to be able to protect our population going out in their communities again? And until we have that vaccine or possibly a treatment, it's on lockdown in the hospitals. And no one knows the answer to this question right now. Everyone is going to be pushing in the next 2 months to resume the economic engine, both in the hospitals and in our communities as well as globally. What is that going to look like? Without a vaccine during that time period, there will be an increased transmission rate. What we're really trying to do right now is not to overwhelm the system so that we can offer each person the best case of survival in the next 2 months. Does that answer your question, Marsha?
I think it's as close as we can get. It's a very fluid situation. We've been trying to stem the tsunami wave of this curve in order to not break the healthcare system. But again, I think we all have to be cognizant that the risk is still out there, again, until we get that safe and effective vaccine. And as you said, the hospital is a business. It needs to make money to thrive, to offer healthcare. And it'll be interesting. Interesting what you said about maybe a split hospital, until we do have that vaccine. So thank you.
We have about 5 minutes left, and I know David Chapman had a question, Kelly had a question, and then there was also the question, this might be a quick answer, about dogs. Do dogs carry this, and why can't you pet your dogs?
So currently, the understanding, cats actually get it, but dogs carry it on their fur. So in general, dogs have not been getting sick. The one case they had was in China, and the person wouldn't let them do an autopsy to see if the dog died from old age or COVID. But the big thing is that it does get on their fur and it is carried. And since it can survive on surfaces up to 2 to 3 days, your dog can become a vector. So that's really the biggie. Smaller animals, if anybody has ferrets, they are highly susceptible to COVID. Just to make sure we cover the ferret population.
Yeah.
As far as individuals to help the healthcare community right now, the number one thing is encouraging people to socially isolate. And as Marsha was saying, keep the curve flattened. Let us take care of these people. It takes 2, 3, 4 weeks to get somebody off a vent. Let us get people off the vent before more people come in. That really changes a lot of it. The other one is not going into the healthcare system unless you really need to. And that's becoming more difficult as primary care physicians are closing their doors. The use of telemed or how to access has become a lot more difficult. I still see a percentage of people who show up in the ER because they can't go anywhere else to get their refills. And the thought of somebody sitting in the waiting room surrounded by COVID because they want to get a refill on their blood pressure medicine, that's a system breakdown nationwide. And so that's kind of what I would recommend in terms of helping the healthcare system.
Thank you for that. Now, David, are you still here? Because he had a question as well. All right, I'm going to turn it back over to you, Doug. And thank you so much. This has been.
Can you hear me now?
Oh yeah, there you are. There you are. Go ahead.
Yeah, I'm sorry, my muted on my end. A couple of things. First of all, Tracy and Greg, thank you so much. You're awesome parents and amazing as a team. I know Dr. Tracy Stiller was familiar with the concept of caregiver fatigue. Well, now you're the caregivers for so many people. And having experienced that personally in the care of my family members, I tried to think, how could I help? Well, they saved my life at St. Anthony's in that ER. And Dr. Lazar was my cardiologist. I got a stent, and I'm doing great, and I wanted to give back. So I'm not sharing this with everybody for recognition. It's something you can do. I catered food into the ER at St. Anthony's last week, and they've got a process. And we can all do this. We can take turns, and it's not very expensive. You look at a staff of probably 30 people in the ER, and the process that St. Anthony's has, and the policy of the people delivering the food is they don't go in. Somebody, usually it's a charge, will get a couple of people. They'll come out and get that food and bring it in. Why is that important? Even though they have catering at St. Anthony's, it doesn't always mean that people that are running to grab a bite from one room to the next or one procedure to the next or whatever the circumstances may be from triage all the way through, just grabbing that bite can make a difference in their energy levels, knowing that it's there. So believe it or not, they'll eat pizza and pasta and salads, but it does make a difference, and they are greatly appreciative. And then I have a question for you, doctors. I'm familiar that there's type A, type B, and type C strains. If you can validate that, 1, great. 2, if you got B, could you end up getting the daughter C?
Excellent question. Yes. So viruses are successful because they mutate. And again, drawing on the example of the flu virus, which we expect mutations every year, we follow those mutations and develop a vaccine based on what we've seen in China 6 months before for what we dose and how we treat our patients here. COVID will mutate. That is what viruses do. Now, could it mutate and be less virulent to the human population? Well, it could be that as well. But the mutations are going to be expected. They're going to be followed. And the development of any vaccine is going to be trying to pinpoint a standard protein that's shown on each of these mutations. So we don't try to follow the individual mutation. We try to come up with a common protein that we can develop a vaccine against. Yes, so could you get A and then get B? You could, but if we could develop a vaccine that addresses a protein that's present on A, B, C, and D, a standard protein on a virus, that's a successful vaccination.
Great. I hope, Greg and Tracy, you're able to read the chat and read all the gratitude that is there for you in our chat. I also want to let everyone know we do record this, and this presentation will be up on our Facebook page. So if you want to share it with friends, colleagues, invite people to future meetings, all of that is on Facebook so that you can share this. Doug?
Thank you for having us.
Thank you for having us.
Mindy, thank you. And Greg and Tracy, thank you very much for the program today. I count